evening, students. So today I am going to deal with the topic of fibroid. It's the most common topic and you get plenty of questions from this. So I am going to tell the topic in the subheadings of what it is actually, what is the etiological features for it, the classification, what clinical symptoms they present with, what are the investigations we do, what are the treatments, and as this is the era of always recent advances, what are the recent advances we have in the fibroid we'll be discussing. So first let's go to the why is the fibroid important to us, or what is most important it is the most common benign smooth muscle pelvic tumor. So the question here is the MCQ purpose. It is the most common benign pelvic tumor. And another question which can be asked about the fibroid regarding the most common is, it is most common solid tumor of the pelvis. So what is the etiological features of it? This tumor is monoclonal in origin. It is monoclonal in origin, and 50% of the time it is because of some chromosomal translocations. So 50% of the time it is because of chromosomal translocations. The main translocation is between the long arm of 12 and 14. And one more important thing about the fibroid is estrogen and progesterone. Initially they were thinking it is only because of estrogen, the fibroid is estrogen dependent, but now what we have found out is even progesterone also helps in the growth of the fibroid. So the etiology, estrogen and progesterone dependent it is. So now the MCQ purpose, see most of the times we can't go on by hearting things, what are the risk factors for this, what are the risk factors of, we should have some conceptually also we should be knowing the things. Like now, because this is an estrogen dependent tumor, benign tumor, so what are all the conditions where estrogen will be more, they are more prone for getting the fibroids. Okay. So and one more thing is nulliparous patients, that is patients who don't have a child. Okay, nulliparous patients have fibroids. It was told the womb which doesn't get to carry a child satisfies itself by carrying this fibroid. So nulliparous is a state where the estrogen levels are high. That's the reason nulliparous patients will have more prone for fibroid. This is an MCQ. And fibroids are more common in nulliparous. Okay. And obesity. Obesity is again androgen, increased in the androgen levels. More the androgen, more is the conversion to the estrogen. So there they are more prone for the fibroids. Okay. So this is regarding the etiology of the fibroid. So in the etiology of the fibroid, mainly we have to know that it is a monoclonal in origin. It is mainly because of the chromosomal defects. 50% of them are because of chromosomal translocation. Mainly you have to remember that there is an exchange in the long arm of 12 and 14. It is mainly estrogen dependent, and the important thing, one more thing why we have to remember estrogen dependent is the patients who have reached the menopause. After menopause there is no estrogen. These fibroids tend to regress in size. Okay, and they are more prone in nulliparous and obesity. Next thing is smoking is protective for fibroids. Smoking is the etiological factor for many things, but here I am stressing it because you might get confused when they give in the risk factors. Smoking is protective for fibroids. There is one more condition where smoking is protective. To our surprise, smoking is even protective for PIH, that is pregnancy induced hypertension. Now let's go to the next is classification of fibroids. So in classification of fibroids, we have uterine fibroids and extrauterine fibroids. Extrauterine is outside the uterus, so it can be the cervical fibroid, it can be broad ligament fibroid, or it can be parasitic, somewhere in the abdomen. Okay, so extrauterine we have cervical fibroid, broad ligament fibroid and parasitic. In uterine we have again mainly the three things. We have submucosal fibroid. This is the submucosal just beneath the mucous membrane. Then we have intramural fibroid which is in the myometrium. And then we have subserosal, that is below the serosa layer, the outermost layer of the uterus, subserosal layer. Now the MCQ asked here is, which is the most common type of uterine fibroid? Most common is 75% is intramural fibroid. 75% of the fibroids are intramural, and these intramural fibroids can either transform into submucous or they can transform into subserosal fibroids. So 15% of them transform into submucosal fibroids and 10% of them transform into subserosal fibroid. The most common type is the intramural fibroid. Okay? In extrauterine, so this is the uterine. Now in the extrauterine, the cervical fibroid, we have anterior fibroid, anterior cervical fibroid, posterior cervical fibroid, and on the center, central fibroid. Central fibroid. Then we have the broad ligament fibroid. In broad ligament, we again have the subdivision as true broad ligament fibroid and false broad ligament fibroid. So there are many questions on broad ligament fibroid where they tend to confuse us, telling it is medial to ureter, lateral to ureter by changing the words. So if our concept is clear here, we can easily make it out by reading the sentence and we can make the answer. Okay, so let's see what is actually true and what is false broad ligament. So this is the uterus, the fallopian, and we have the broad ligament here, and always ureter comes from the lateral to the medial. So the fibroid, false broad ligament fibroid is a fibroid. It is mainly a subserosal fibroid which is arising and which is going into the broad ligament. So it is a fibroid which is actually from the uterus which is going into the broad ligament. Whereas true broad ligament fibroid is the one which is in situ, which has grown in situ in the broad ligament. Which has grown in situ in the broad ligament. Now the questions which they ask is, true broad ligament fibroid is, it is lateral to the ureter. Okay? Or the false broad ligament fibroid will be medial to the ureter. Or they might ask, there is a fibroid which is located medial to the ureter. It is a broad ligament fibroid or it is a false broad ligament fibroid. They can give you options like that. So this concept you should be clear that ureter, in a true broad ligament fibroid, ureter is medial, whereas in a false broad ligament, ureter is lateral. Okay? And for clinically also for a gynecologist, it is very important to know the fibroid origin, whether it is coming in situ in the broad ligament or whether it has come from the subserosal into the broad ligament, because while operating, we are very concerned regarding the ureter. So position of the ureter varies depending on the type of the broad ligament fibroid. So this is regarding the classification of the fibroid or types of the fibroid. Now let's go to the clinical features of fibroid. The clinical features of the fibroid mainly depends on the site of the fibroid. Each type of fibroid will produce a different type of symptoms. But the most common symptom of fibroid is they are asymptomatic. More than 50% of them are asymptomatic. Okay? Then what are the symptoms with the patients present with the fibroid? First is the submucous fibroid. Submucosal fibroid you can see is just beneath the mucous membrane. So what happens to the mucous membrane as the fibroid grows? The surface area of the fibroid, the surface area of the mucous membrane increases. When the surface area increases, there will be increased bleeding. So submucous fibroid will present with heavy menstrual bleeding. Now note my words, I am not telling menorrhagia anymore. So because there is no more word called menorrhagia, menometrorrhagia and all. Now what we have, the terminology is only HMB or heavy menstrual bleeding. Any prolonged bleeding more than 8 days or more than 80 ml is called heavy menstrual bleeding. Okay. So submucosal fibroids will present with heavy menstrual bleeding. Next, coming to our intramural fibroids. So intramural fibroids are within the myometrium. What happens when the endometrium has to shed out? Myometrium will squeeze to push the endometrium outside. But when there is some obstruction in it, it tries to push it hard. So intramural fibroids present with dysmenorrhea, that is painful menstruation. And the type of dysmenorrhea is congestive dysmenorrhea. Any dysmenorrhea because of some secondary causes is always called secondary dysmenorrhea or congestive dysmenorrhea. So intramural fibroids mainly present with congestive dysmenorrhea. And last are subserosal fibroids. Subserosal fibroids are outside the uterus. They are not disturbing our uterus in any way. So most of the time they are asymptomatic. But they are dangerous. Why? In subserosal, if they have a stalk, we call it as pedunculated. If they don't have a stalk, we call it as sessile. They are prone for torsion, which is a medical emergency. That's the reason they are dangerous. So the main symptoms in most of them are asymptomatic, more than 50%. The other symptoms of the menstrual disturbances which they present with are dysmenorrhea and heavy menstrual bleeding mainly. Apart from that, some patients can present with infertility depending on where is the site of the fibroid. Like if it is blocking the cornea and not letting the ovum or sperm to get inside. So they can present with infertility. Then next comes the pressure symptoms. So we have the pressure symptoms. Most pressure symptoms depends on the site of the fibroid. So any fibroid which is on the cervical, anterior cervical fibroid. See, cervix is here, in front will be our bladder. So any fibroid in the cervix will irritate the bladder. So anterior cervical fibroid will present with increased frequency of micturition. And posterior cervical fibroid will go and sit in the pouch of Douglas. Posterior cervical fibroid will go and sit in the pouch of Douglas and it will cause kinking on the urethra. So they present with retention of the urine. These are MCQs. Retention of urine in a fibroid is most commonly because of posterior cervical fibroid, and increased frequency of micturition is because of the anterior cervical fibroid. Okay, so these are regarding the clinical features. In clinical features, most commonly which we should know or which are asked as MCQs are most common symptom is asymptomatic. More than 50% are asymptomatic. And most common menstrual disturbance which they come is heavy menstrual bleeding, which is caused by submucosal fibroids. Dysmenorrhea is caused by intramural fibroids. So this is